Hi, this is Dannette, and this is my observation 2. It was an inpatient hospitalization I just started with the intensive care portion. The demands that day were to improve the independent respiratory function and secondarily to determine treatment for a compression fracture that had happened in the lower lumbar area. It was a mess. If I had been an interpreter in the situation, I would have called for a CVI, I would have called for a team because we would have needed probably pretty frequent breaks. It was extremely intense, and if I had not lived this situation before with a family member, I would not have had any idea what to do. This actually was my father, so I used the situation because it was very pertinent to something that could happen in an interpreting situation, and I've been an observer to it several times, so I decided it was appropriate to use. The ICU room was packed. As you know, when you go into ICU, we've already gone to emergency at this point, been taken to ICU. There's pulmonary equipment in there. There's monitoring. You've got the setup on both sides of the bed for any kind of hanging fluids, IVs, blood transfusions, antibiotics, whatever you may need. There's a lot of computer equipment so that the nurses can monitor the situation at all times. There's typically 2 nurses in the room as things are being set up. As an interpreter, they would have let me stay in the room other than the first 15 or 20 minutes when they have to have the privacy to set the patient up, have their internal dialogue that's not to be overheard. In this case, the patient was pretty much non-responsive. If the deaf patient had been in the same situation, I would not have felt like I needed to challenge the decision to have me out of the room. It would have been appropriate at that time. It was a very large ICU room, communication boards, 4 oxygen ports coming out of the wall, lots of busyness, lots of staff. The personnel, the doctors that were involved with my father, although he was there because he was having respiratory issues, he was taken to a hospital where all his specialists work in the hospital. So the patient was an 83-year-old gentleman. You had a pulmonary doctor, a urologist, an orthopedic, a kidney doctor, the attending physician, which is also his primary care physician outside of the hospital. Due to the nature and severity of his illnesses, he functions in both roles, which is unusual. An oncologist on call, various RNs. Actually, we were on an ICU floor where they were familiar with him. So again, as an interpreter, had I been faced with all these specialists and all these doctors coming in and out, if I removed myself from the situation, it was the interpreter watching the family member interact, it would have been extremely overwhelming. The familiarity of the situation, the fact that the patient was pretty much non-responsive, at that point, I would have just been kind of hanging out, hopefully cognizant enough to be gathering information, taking notes, finding out what the situation was going to be. They expected the patient to come around once they gave the patient oxygen, reduced the carbon dioxide level, so the interpreter would have been there for the time when the patient became alert, was wondering where they were, making decisions, working with family members who potentially could have been deaf as well. A lot of terminology that for any interpreter, if you haven't done a lot of medical work in an emergency setting, they're talking about renal function, which is kidneys and stents, and the creatinine level and everything that goes with renal. And then you've got pulmonary, and you're talking about CO2 and O2 and volume and fluid on the lungs. You've got ABG, blood gases going on in the wrist, which for a patient that is awake is a painful way to take a blood gas to test the CO2. I don't know if there was a good way to prep for all the different things that were occurring during this time. As a seasoned interpreter, someone would have had more experience with some of the terminology, but a lot of it was being thrown around very, very quickly over a period of about 3 hours. Intubating the patient did have a tube, so that meant when they woke up, if they were deaf, they would be able to use their sign language as they became more alert. However, many times with intubation, interpreters run into a problem that patients, because of a high CO2 level or because of fluid or confusion, even a urinary tract infection, can make you not as clear as you need to be in a given emergency situation, which makes them pull at tubes and take off masks and try to take out IVs. Many times we're going to see a patient either with the large hand mitts on or loosely strapped down to a bed for their safety and the nurses to make sure that everybody is okay and that medical equipment stays in its place. And in that case, as an interpreter, I would have erred on the side of comfort, watching the hands. I think Jillian has given me an option that I hadn't thought of before, and that would be to possibly, try tactile interpreting at that time if their hands were not available to freely sign, being able to spell in their hand. They can see me, but they wouldn't be able to respond back in a way that's fluent for ASL. So thinking about that in different ways that I would lessen the stress in that situation for a deaf patient. Talking about home ventilators, leukocytes, red blood cells, white blood cells, infections, oxygen sats, tubes, nutrition, what were they going to do? The secondary spine fracture, were they going to do an MRI? Were they going to wait? The patient was not awake at this point. It was a big mess. As an interpreter, it would have been extremely challenging. Brief notes on the patient's history that an interpreter may or may not have found out about were some pretty serious life-threatening issues in themselves over the last several years, which complicate every current visit to the ER and to ICU when the patient is admitted. Several cancers, radiation-induced neuropathy, bilateral kidney stents, colon cancer. Fistula was removed last year in December. Knowing this terminology, knowing what it means, not necessarily interpreting it. This is medical information. This is what the doctors and the nurses and the specialists are consulting about. It could be overheard by the interpreter, who I'm hoping is taking at least mental, if not written notes, to go back and post-review the things that happened, because there was no way to really prepare for this. Chief complaint was the admission to the emergency room in the middle of the night by the assisted living staff where the gentleman lives for lethargy, not responsive. They assumed high CO2 and a urinary tract infection. It was not a patient chief complaint. It was an emergency situation. Primary care from the rehab assisted living was not there. As I mentioned, the attending doctor for the hospital primarily is also considered my dad's primary care. The specialists were fantastic. They worked in conjunction with each other. There are not a lot of mistakes made, which is nice. As an interpreter, trying to weed out which specialist is responsible for what and how they're going to approach this situation once the patient wakes up and can begin making decisions, or if they don't wake up and the family members need to make decisions. There was a lot of activity that did not involve the patient at this point. Nurses attending to the respiratory needs, talking to family members, gathering more data and history, asking, for things to happen, that some things were complied with by the family, some things were not complied with because of previous knowledge, history with the patient. Paralinguistically, if I was an interpreter, I would kind of be at loose ends. The patient was not alert, could not give a self-report. It was coming from previous history that was in the portal from previous stays and self-reports from the family. If the family had been deaf, then I would have had a role and I would have been able to, at this point, utilize my skills and be involved in the situation. If not, I would have been somewhat of an observer myself if it was only the patient that was deaf. Once the patient woke up and tried to talk through the tube, of course, it's painful, it's frustrating. There's a lot of anxiety produced for everybody, probably except the nurses in the room, because it's very hard to watch someone tubed trying desperately to communicate when they're not completely with it. You don't understand them. They've got something to say. Hands were shaking. He really couldn't write down. We've utilized that before. That's a possibility for, a deaf person as well, if we can give them something to go with and feel like, okay, I'm going to write down what I think you're saying and kind of show it to them. Trying to think of different ways that an interpreter could have been utilized. There was a very kind male nurse from Nigeria, could not understand a thing he said, had to ask him to repeat several times. An interpreter would have had to do the same thing. Would you mind repeating that? I want to make sure, because this is, a medical situation, that I get it correct. Lots of dialogue. This went on for hours, days, but I just picked one day. Vital machines, they're beeping, it's loud, there's distractions, there's people in and out, there's bright lights, it's not conducive to sleep in the ICU. So all of this the interpreter would have been having to process as the demands just kept rolling to the front to make sure that they used strategies and controls that were going to help the situation and not allow themselves to hinder it by being distracted. Talk of diagnosis, treatment planning, follow-ups. I'm over my 10 minutes. Interpersonal demands. A lot of people in the room, in and out, were talking about end of life. Some people were talking about level of functioning. Specialists that were more familiar with the patient came in, kind of took over the situation, which was nice. So the initial diagnosis that they thought in the emergency room did not follow the patient up to the ICU. And you can kind of see some conflicts, miscommunication that occurred. Adult children have POA. The patient was not supposed to be intubated this time. They were without having consent. Nobody looked at the paperwork. That would have been a discussion that the family would have had to have with the doctors through an interpreter if they had been deaf. The top 5 demands that I saw for interpreting were, what do you do with a non-responsive patient? You can't get history. You don't really know the reason for admission except the little bit that's there. There's a high level of pain. It prevents some tests and some examinations. Intubation further complicated the situation as a deaf patient would wake up. The patient's normal level of functioning is not known to the ED staff, the ICU staff, or the interpreter. There's many cases where a person could be brought in by themselves. If a deaf person is living in a city where their family is not readily available, it could be you, the staff, and the deaf patient. A lot of things to consider and to work through in this kind of situation. I think I'm going to stop there. You can see some of the controls, pre-assignment controls I had. An interpreter coming into the situation probably would have only known that they were coming into an emergency situation that turned into ICU and wouldn't have a lot of information on the patient other than, now that I think about it, the patient was a frequent flyer to ICU. The interpreter may have been an interpreter, hopefully sent on the job, that knew the situation, was familiar, and at least had a schema built of what the patient's history was. Not that they need to provide it, but that they know it. That way it makes the flow of the information more accurate, less stressful for the interpreter, and could potentially help the situation. Anyway, sorry I went over. Thank you.